Welcome to The Explainer, practitioners. Today, we're jumping right into a true clinical masterclass on OCT interpretation, specifically tailored for South African practices. This entire session is drawn directly from the essential teachings and clinical insights of Dr. Dirk J. Buesen. So let's dive right in and elevate our clinical game, shall we?
Here's a quick look at our roadmap for today. We'll be covering the diagnostic dilemma, diving into the whole structure versus function debate, finding a much better landmark, exploring the BMO-MRW standard, and finally, grounding all of this in actual South African clinical realities. Let's get to it.
Section 1. The Diagnostic Dilemma. What is the fundamental challenge we face the second a suspected glaucoma patient sits in our chair?
To really grasp the dilemma, we have to ground ourselves in the basic science. Konski's clinical ophthalmology reminds us that glaucoma is, fundamentally, an optic neuropathy. But the massive catch here, it brings a severe risk of progressive visual field impairment. It's that word progressive that literally keeps us on our toes, right? Because how this disease unfolds over time varies so wildly from one patient to the next.
Now here's a stark reminder, straight from the European Glaucoma Society guidelines. Your incredibly high-tech OCT machine, it doesn't actually diagnose glaucoma. I know, a bit shocking. It literally just spits out a statistical result based on a normative database. A true, reliable diagnosis absolutely requires your clinical interpretation. You've got to combine those imaging results with the patient's actual functional visual ability. Because at the end of the day, preserving their quality of life and preventing severe functional impairment is the whole point of what we do. Moving to Section 2, Structure versus Function. This highlights a timeline of damage that can honestly trick even the most experienced clinicians out there. Let's break down what we actually see in the exam room. On one side, you have structural defects. These are the physical changes the OCT actually picks up, like RNFL loss, which often hides out in areas of high retinal redundancy. But then, on the flip side, we have functional defects. This is what your patient is genuinely struggling with on a visual field test, often because their retinal ganglion cells become totally dysfunctional way before they actually die off. And that brings us to the real heart of the confusion. When we look at Bartlett's text alongside Dr. Buesen's analysis of major trials like the ocular hypertension treatment study, we hit this fascinating reality. Finding a structural defect and a corresponding functional defect at the exact same time in early glaucoma is actually incredibly rare. You'd logically expect them to show up hand in hand, wouldn't you? But in the early stages, they almost never do. So here are the core clinical pearls you absolutely need to remember. Sometimes structural defects show up first. Other times, functional defects beat them to the punch. The relationship between the two is just remarkably weak early on. So what's the big takeaway here? You absolutely have to monitor both the visual field and the optic disc with relentless diligence. You just can't rely on a single test to tell you the entire story. All right, Section 3, Finding a Better Landmark. Since that early correlation is so weak, we desperately need a better anatomical solution to catch this disease early. Faced with all this noise from statistical databases and weak early correlations, we have to ask the critical question Dr. Buesen poses in his masterclass. How on earth do we as clinicians simplify our OCT interpretation? We need a method that cuts through the noise and delivers real diagnostic clarity. Well, the answer requires a total paradigm shift. For years, practitioners have leaned heavily on the conventional clinical disc margin, Elschnig's scleral ring. But we've got to move past this. It is time to abandon old, highly variable landmarks and completely embrace a much higher standard of precision. Which brings us right to Section 4, the BMO-MRW standard. This is where we adopt that far superior anatomical baseline to truly protect our patients. When we look at this new standard on a spectral domain OCT scan, the key is finding the BMO, or Bruch's membrane opening. It marks the exact termination of the retinal pigment epithelium layer. And let me tell you, compared to the old clinical disc margin, the BMO is a significantly more reliable, incredibly stable, and totally objective landmark. It is a total game changer. Now, how do we make this actionable? By measuring the minimum rim width, or MRW, straight from that stable BMO landmark. This gives us the BMO-MRW measurement, which has absolutely become the gold standard for documenting neuroretinal rim dimensions. It's a highly accurate way to diagnose glaucoma, and the best part, it correlates so much better with true visual field damage.
If you want a precise diagnostic anchor to use in your clinic tomorrow morning, lock this number into your brain. The mean BMO MRW measurement in healthy eyes sits right between 265 and 318 micrometers. Keep that specific range front and center the next time you're evaluating a scan.
Finally, Section 5, South African Clinical Realities. Let's take all this high-level science and apply it directly to the everyday realities of our local clinics. We constantly hear all this hype about the future of automated diagnostics, but Dr. Boasen brings us back down to earth with a very practical reality. AI is expensive. Sure, artificial intelligence offers massive promise for the future, but it's just not accessible to every practice today. And you know what that means? The immediate responsibility for an accurate diagnosis rests entirely on your shoulders. We have to be the masters of interpretation. So, here is your real-world clinical mandate. First, you have to intimately understand your specific OCT equipment and exactly what it is measuring. Second, understand your specific patient population. For South African practitioners, this is the absolute core challenge. The standard normative databases built into these machines often totally fail to reflect the unique realities of the South African demographic. Because we don't readily have local normative values, you have to actively build your own clinical knowledge of what's actually normal for your local populations, macular, choroidal, and RNFL thickness. As we wrap up this explainer, I want to leave you with one final, truly provocative thought. Are you just passively relying on a generalized, possibly inaccurate machine database to flash a green or red light for your patient? Or are you actively applying your clinical mastery of specific patient demographics using superior landmarks like the BMO MRW to genuinely protect their vision? Remember, the machine is just a tool. The actual clinical diagnosis comes from you. Keep learning, keep questioning, and keep mastering your craft.